everybody. Welcome and thank you so much for joining us today. Today we're going to be talking about cutaneous B-cell lymphomas, CBCL. Before we get started, I would just like to give a thank you to our corporate partners and our individual donors. Thank you so much for supporting us and for allowing us to put these programs on for you. So today we have Dr. Christiane Querfeld. Dr. Querfeld, thank you so much for joining us today. Dr. Querfeld is from the Beckman Research Institute at the City of Hope National Medical Center. How are you today, Dr. Querfeld?
Excellent. I'm very excited to present here to all of you. And I'm also excited that we're talking about B-cell lymphomas because it's always, we're talking a lot about T-cell lymphomas. And I think even if it's B-cell lymphomas are rarer than the T-cell lymphomas, but we do see patients, and I think they all have the same questions, concerns, and so today is just ideal, and I'm very happy to show some information, share some information with you all, and can also answer some questions after the presentation, and so that nothing is left behind.
Wonderful. Thank you so much. Yes, and we are very excited to have your expertise. I know we have a lot of folks who ask us for specific B-cell information, so it's really wonderful to be able to provide that today. So I'm going to go ahead and share your slides here, and I will turn things over to you.
Yes, so we're talking about skin B-cell lymphomas, and next slide, please. And these are my disclosures. I work with several companies on advisory boards. We have also trials, and that's why I'm an investigator for those trials. Next slides. So when we say skin lymphomas, and so lymphomas can develop from either T lymphocytes or B lymphocytes. These are white blood cells. And skin lymphomas are lymphomas that develop in the skin and have not affected any other sites of the body at the time they're diagnosed. They're strictly limited to the skin. And B-cell skin lymphomas are skin lymphomas that develop from B lymphocytes, or so-called B cells. B-cell lymphomas of the skin are rare. They're rarer than T-cell lymphomas of the skin. And we know that there is an association with an infection. It's Lyme disease, we call it, or Borrelia infection. And this has been seen mainly in Europe, in European countries. Next slide. So when we look at, and this is just an example, and at our center, but it's similar to every center that treats patients with skin lymphomas. Roughly, I would say 20% of all skin lymphomas are B-cell skin lymphomas. And what you can see here in dark blue, so it's roughly, you know, in our center it's 13%, but you know, it's a small piece of a tart. And the rest of it is more like, you know, in the T-cell family. Next slide. So when we talk about B-cell skin lymphomas, there are really three types that you want to know or you need to know. And we have, these are the major types. It's called follicular lymphoma, marginal zone lymphoma, and diffuse large B-cell lymphoma, leg type. So while follicular lymphoma and marginal zone lymphoma, these are low-grade B-cell lymphomas. The most common is the follicular lymphoma, followed by marginal zone lymphoma. And the prognosis is really excellent. So patients do really well. A lot of studies have confirmed this. So the diffuse large B-cell lymphoma, leg type is unlike the other two. It's more high grade and it's less common and has also less favorable prognosis. It's not a poor prognosis, it's a more serious prognosis which requires more attention and treatment. Next slide. So what are the symptoms? What could be, you know, that points out to a B-cell skin lymphomas? It could be a single lump in the skin. And sometimes patients have multiple lumps in the skin. And often looks like a bug bite that's growing. It could look a little bit like an eczematous patch or a pimple. And appears, so when we see, most commonly it's the head involved, the back, shoulders, or legs. They can be itchy or have, in most cases or many cases, no symptoms. And the body site is specific actually to some B-cell skin lymphomas, meaning where they're in, meaning specific sites like the head could point out to a specific B-cell lymphoma like the follicular lymphoma. While if arms are more involved or legs, this could more point out to a marginal zone lymphoma. Next slide. So this is just an example, you know, this is one on the face, and then this is on the back, you see a lump, right? And then, so this is usually like a red lump. This is what you see. Next slide. Next slide, yeah, good. Okay, and so how do we diagnose a B-cell skin lymphoma? And the importance is the most important is really the pathology review, the skin biopsy, the pathology review, and you know, specific stains, markers you apply to skin sections. And you also need staging, meaning like a thorough skin exam and additional blood tests and possibly scans to make sure that we are dealing really with a pure skin lymphoma and not with something that's developed internally in lymph nodes that spread to the skin. Next slide. So this is something, you know, this is just a few shots, and this is because I'm also looking at slides. And so on the left side, you see follicular lymphoma that sees little nodules in the skin. And it's very dense infiltrate. And on the other side here, the marginal zone lymphoma presents more like, you know, it's tracing more like the adnexal structures going down between. So it's not as dense often. And so based on this quick shot, you can also have an idea what you're dealing with. But of course, you need more specific markers to really confirm the diagnosis. So next slide. So when we talk about staging, and as with other cancer, you know, B-cell skin lymphoma is a cancer, yes, what do we need to do? And so the important is the complete history. It's you, actually. What you're telling us as a patient is very, very important. It's actually, I think, the most important to capture, you know, how long you have it, where it was developed, was it a single lump, multiple lumps, what happened, and whether it gives you some trouble, pain, itching. And then we look at the skin, we look at the skin, but we also examine everything. We check for lymph nodes that are maybe growing or larger, and then we do blood tests. That's very important to make sure that nothing, or to really see that nothing is internal. And we also check for certain markers for infection. We know that very important, what I mentioned before, it's associated with Lyme disease, could be. So we check for this in the blood. We also do, for sure for the high-grade B-cell lymphomas, we check imaging studies, which are called PET or CT scans. It's from head to toe to make sure that nothing is inside. A bone marrow biopsy is in general only needed for the diffuse large B-cell lymphoma leg type. It's really optional for the others. We rarely, I mean, we don't do this in our patients with marginal zone lymphoma, and rarely in patients with follicular lymphomas, but only if there is a question whether it had come from the inside. And that's why we're doing this. But otherwise, in general, we don't. So remember, only really important for the diffuse large B-cell lymphoma lead type. Next slide. So additional tests, there are, it's called ANA, and this is a marker for autoimmune diseases. And the Lyme titer is again for Lyme disease. Certain infections can mimic a lymphoma, which is syphilis, Helicobacter pylori, and even hepatitis. So we want to make sure that we are checking this to rule this out. And not everyone needs those tests, but these are additional tests. What we know, even autoimmune disorders, such as lupus or Sjögren's, they sometimes can actually look like a B-cell lymphoma, and that's why we check this marker. It's very, very helpful. In particular, the marginal zone lymphoma, which is this second most common low-grade lymphoma, can be associated with immune with lupus, or we have seen patients who had Helicobacter pylori infection. There is a common lymphoma in the stomach, actually, that can be caused by this infection, which is you just treat it with antibiotics, and then it's gone. So next slide. So this is, for example, of a patient with a follicular lymphoma. So why I'm showing this picture, because the follicular skin lymphomas, they are usually, they're more common on the head or on the back. And they're really low grade. There's a risk that it really spread inside or to nodes is very low. It's in 5 of 100 patients, 5 to 10 of 100 patients. But so what we know is relapses are very, very frequent. About 50% of the patients can have a relapse in the skin, can be the same area or can be a little distant from the area. The relapses don't change the prognosis. That's very important to know, okay? So even if it comes back, you're still doing well with that in general, okay? So the next slide. This is a marginal zone lymphoma. I'm sorry, it looks a little blurry, but what's important, this is on the arm, and usually younger patients are getting this. It's very, this is very typical. Usually comes also as a single lump, but here this patient had 2 lumps together there, and very common on arms and legs. And we know that there have been studies that looked Lyme disease can be associated with that. And it's also, the last point here, it's also can be associated with autoimmunity, like lupus, what I mentioned, or GI problems. If you have some, chronic infections in the stomach, this can sometimes happen. And that is also associated with frequent, relapses, 40 to 50% nearly, also, and which is also fine. It's maybe, nobody wants to have relapses, but even if it comes back, your prognosis is still the same, okay? So it's very, very, very favorable, and really, really spread inside the body. So that's why, that's really a very low grade lymphoma. So next slide. This is a example of diffuse large B-cell lymphoma leg type. This is how they can look like on the leg. And there are, some usually there are multiple small bigger lumps together. And this can be is most commonly presented on the legs, on the lower legs. And typically what we know is older patients. It seems also like women are more affected than men. And also is relapsing frequently, and however can spread inside the body. So this is more aggressive, meaning like it's more high grade. And this is a lymphoma we really need to pay attention, make really clear that we have, this is the right diagnosis, because this definitely needs systemic or combination therapy, okay? And next slide, please. So what we call is, and it's very important, a so-called risk stratification. So which means, like, first of all, we have your history, but then we have the histology, we have a biopsy, and this is the most important actually. And if someone is experienced, so we have, have to have a clear-cut diagnosis. Is it indolent, or is it the high grade, or meaning like indolent low grade, or is it high grade? And both the follicular lymphoma and the so-called marginal zone lymphoma are low-risk lymphomas, rarely spread, with an excellent prognosis. And the diffuse large B-cell lymphoma leg type is a more high grade and has less favorable prognosis. It's not poor prognosis. We still have good chances, but it's more aggressive. So we need to take, really more action and treatment, make sure that we're doing the right thing. Next slide. So when we have, in general, there are some treatment principles, and there's no, if we have a low-grade B-cell lymphoma and sometimes blood tests show an infection, sometimes not, you may start out just treating with an antibiotic first and see, and sometimes these low-grade lymphomas even shrink with just antibiotics. Both low-grade lymphomas, follicular lymphoma and marginal zone lymphoma, they are treated the same way. So, and what we do here, and many do, we can watch it. It depends, it depends on my patients. If someone says, I don't want to have treatment, if you're telling me it's a low grade, and I said, I'm okay to watch it as long as you come back, and so that we can take a look and see and examine you. Or we can have intralesional injection with steroids, and this goes away. If it's a single lump, we can also do surgery, or we can apply a couple of rounds of radiation, like into the skin, to the area. If there are more areas infected, we still can watch it because it's, still indolent, low grade. We still can do the intralesional steroid injection, or we can do radiation. We would not do localized surgery to multiple lesions. And if the lymphoma is really very widespread everywhere in the skin, which happens, there may be a systemic treatment as an option, a systemic antibody treatment. It's called rituximab or Rituxan, and it can be given a few courses, and usually 4 treatments. But this is, decision really, if it's widespread, if you think you want to be treated, and if your doctor also thinks you should be treated. So what definitely needs to be treated once we have established a diagnosis is the high-grade skin lymphoma. Okay, we cannot really wait. And this is usually treated with systemic therapy, and can be treated with systemic therapy in combination with radiation or radiotherapy. A lot of patients can be also included in clinical trials if they're treated in an institution where we have clinical trials available. There are now immunotherapies in combination with chemotherapy, or so-called CAR T-cell therapy. However, this should not be the first line therapy. There should be the established treatments that has been given, the systemic combination chemotherapy with radiation therapy. if a patient is, you know, very, very fragile, I sometimes just think, okay, let's do just radiation and follow you if they cannot tolerate a systemic therapy. But otherwise, usually you do a combination. Next slide. So, you know, we have here, so I put a list together, and actually this is one of my fellows who actually looked what's been done for those low-grade lymphomas, and observation, watch and wait, excision, surgery, antibiotics, local radiation. You're treating interlesional with interferon alpha. You can also treat interlesionally with rituximab, which is the anti-CD20, which you know, is a marker of the B cells. And then you have the systemic chemotherapy. It's called CHOP. And in combination, you usually use it in combination with the rituximab, and it's called R-CHOP. Or you can use it in combination with radiation, then it's called radiochemotherapy. But there have been also patients who treated now, you know, just with topical steroids, creams, or ointments, with a topical imiquimod, which is an approved treatment for skin cancer. And also with a miclorethamine, it's called also otherwise nitrogen mustard, which is approved for early stage T-cell lymphoma in the skin. And so-called photodynamic therapy, which is actually a form of light therapy for skin cancer. And there have been others, medication like lenalidomide or thalidomide. There are drugs that are approved for multiple myeloma, which is a B-cell or in a B-cell family, but it's systemic. It usually arises in the bone marrow. And clinical trials. So there's a lot what you can see here in the treatment armamentarium, but the most common things that are really used are watching, surgery, antibiotics, and local radiation, because most of those skin B-cell lymphomas are indolent. And this is again, I want to emphasize it because this is very important to know. And can we go to the next slide, please? So this is a little bit more complicated slide, has a lot of numbers. And so this is a list, you know, these are patients that were published, and a team in Leiden in the Netherlands looked into all the studies and they said, okay, what happened if those patients were treated? Were they cured, or did the lymphoma come back? And actually, when you look what's circled here in the red here is relapses, and you can see it's nearly 50, you know, up to 50%, regardless of treatment. And regardless of treatment, and so it should also highlight, even if you give systemic therapy, you get relapses, and you may not need systemic therapies in indolent B-cell lymphomas. And there's no difference. So I think whatever you choose, that's okay in low-grade lymphomas, but you have to be, you know, make sure that you always follow up with your doctors, and that treatment can be given in case it really gets more widespread. But again, when everything is cleared, there is a high chance that it can come back, as it's shown here. So, you know, half of the patients have a relapse. Again, a relapse doesn't mean it's the end of the world. The relapse can be retreated. There's no downside to it. And the prognosis is still very, very good. Next slide. Okay. So this is my last slide. And there is also an email that can be facilitate it, and you can also email me if necessary, but I'm trying to also answer some questions. This is City of Hope here. This is how we look outside. This is from the hospital when we have patients in the hospital. So thank you all for your attention. Look forward to all the questions.
Thank you so much, Dr. Querfeld. That was really informative, and I just really appreciate you taking the time to explain all of that for us. I know, like I said, we always have specific B-cell questions, so it's just so nice to be able to offer something specifically for those folks. So I know you have a little bit of time left here just to answer a couple of questions that people have submitted, if you don't mind. The first question was, once the initial lesions are treated, how can B-cell manifest itself?
So once they are treated and you don't see the skin is clear, so then we would assume, you know, this is a complete remission, and which is great. This is always the goal. Okay, in indolent, in low-grade lymph, it's always the goal, complete remission. And as it is with all skin lymphomas, there is, however, no really promise for a complete cure. So everything, it can come back. If it comes back, it often comes back in the same side. So if you had a lymphoma on the arm, it can come back on the same arm, but it also can come back on the other arm. So this is what we can't predict, on which side it comes back, but there's a high chance that it comes back. So I want you to keep in mind that it's around 40 to 50%, okay? Meaning, like, of 100 patients who have a B-cell lymphoma of the skin, in about 40 patients to 50 patients, it will come back. It has a chance to come back, okay? So it looks the same. It can look slightly different, but essentially pretty much similar presentation usually. Then you can choose again whether we want to have a treatment or we want to watch it, or you know, these are options. And or you want to have a different treatment. If you had surgery the first time, then you want to say, okay, I want to watch it. That's fine too. Or you want to have radiation. That's, you know, totally. This is all valid options. There's no just one way.
Okay. So the second question, I have B-cell lymphoma and I am using Valchlor once a day on both of my arms. On average, how long is the medication required, and is it common for the nodules to return? So I know you've kind of touched on some of this.
Yes, and so I think for how long, I mean, it's sometimes hard to predict because the B-cell lymphomas can be really bulky in a way. It can be a big lump, sometimes it can be a smaller lump or a thinner lump. So if the skin is flat and you don't feel any resistance, you know, when you touch the skin, and if it's totally flat, then I would say it's probably gone. The treatment itself can also cause some skin redness, and so that's a bit hard to tell. But in general, if the skin, if you don't see the lump, if you don't feel the lump anymore, it's probably a very good marker that it's gone. There are no really data out that looks that tells us how often or if the lymphoma comes back when treated with Valchlor. I think that's because this wasn't used traditionally, and so this is fairly new to also treat B-cell lymphoma. So I would say, in general, knowing the nature of the B-cell lymphoma, it can come back. I cannot answer this question with 100% certainty. So there's a higher chance that it will come back. But if it comes back, you can also restart with the same treatment if you're happy with the treatment.
Okay. So it would continue to hopefully be effective subsequent times. Okay.
Yeah.
What causes it is the next question.
Yeah, good question. In many cases, we don't know. There were a few things what I mentioned in the presentation. It may be due to an infection like this Borrelia infection or Lyme disease, and can cause a B-cell lymphoma. But or if you have an autoimmune disorder such as lupus or Sjögren's, or down the line, it sometimes can cause like an exuberant inflammation in the skin that can develop into a B-cell lymphoma, because it may become chronic, and then all of a sudden it becomes a lymphoma. But we don't know really too many details of that. Treatment with antibiotic works. Treating, these low-grade B-cell lymphoma supports the theory that it's caused by some infection. But we don't really know in most instances. Same basically with the T-cell lymphoma, we also don't really know. It's very because it's also very rare, skin lymphomas in general, and only very few patients have this, unlike the systemic lymphomas. So all data are very scarce, and unfortunately can't provide you with more. Yeah.
Okay. Is there a higher likelihood of contracting it somewhere else on my body? I assume if they already have it.
Well, yes, in a way, but it's not from if you're touching it and you're getting it on the other area. So it's basically, it can, if you have it on one arm, it can potentially show up on the other arm, or it can show up on the back, or can show up on the neck. But this is not meant by direct touching or spread through the skin. It may be that there are still a few cancerous cells hiding inside the body, and they're going into the circulation and settling down somewhere else. This is it's usually in most cases, I think if the lymphoma comes back, it's usually in the same site or similar, very close to the area, so that you have something developed on the head and it develops on the toe. This would be very unusual, right? But if you have something on the left shoulder, it could show up on the left arm, for example, right?
Okay, so closer proximity.
Like, yes, closer, much closer, yes.
Okay, so we have two more questions. How often does B-cell cutaneous lymphoma result in a spread through the body, like in the lymph nodes or bone marrow? And is it a good idea to keep evaluating for that over time?
So yes and no. It's a very good question. Excellent question. So we know that for the indolent lymphomas, so in particular, actually, I think mostly really for the follicular lymphoma, there is a risk that it's spread, and it's about 5 to 10 patients of percent. Basically, if you have 100 patients with that, 5 to 10 have the risk that it spreads. With marginal zone lymphoma, it's extremely rare. I mean, it's very rare. So there are no really actual numbers because it's so rare. If you have a high-grade lymphoma, like the leg type, diffuse large B-cell lymphoma, diffuse large B-cell lymphoma, this is the high grade. This has a risk, has a much higher risk. And for this reason, you really you need to treat systemic therapy to prevent. It can really, if it relapses, it often relapses to the skin, but it can also relapse to inside to the nodes, to the lymph nodes, lymph glands, and to other body sites. And so this is the only really this is the lymphoma that needs attention. And then what was the second part of the question? Sorry, I forgot about.
Is it a good idea to keep evaluating for that over time? And then they noted when the initial evaluation shows no other involvement within the body.
Yes, it's very good. So we don't need, but you know, it's different. So it's a stratification if you want. So if it's an indolent, so for sure clinical visit, you need to, if you have this is a diagnosis you have, regardless whether it comes back or not. And so if patients do really well, you know, after I would say 2-3 years, I think yearly exam is fine if nothing came back. With the high relapses are much higher within the first 2 years. And I see the patients, you know, you should come more often, and your doctor say, well, come back, you know, every 4 or 6 months. But then after you can also say, well, once yearly would be okay. And exam and just general blood tests would be fine. In very, very rare instances, maybe imaging studies, scans can be repeated. Unlike in the high grade, where you always have to come back, and in a much you know, shorter time periods. So you can't wait a year. So it's usually once you're done with the treatment and it's all in remission, then we can say, okay, we follow you every 4 months, or, you know, but scans, you know, if symptoms come, scans have to be repeated. This is something that is more like a regimen that's followed with patients who have a systemic, you know, inside a lymphoma. So that's different, okay? So there is so low grade is low key, but you cannot lose track of follow up. But high grade is always, you have to, be in touch with your team, and they have to make sure that you're doing well.
Okay. And then just one last question here. Have there been any new findings for a cure? I'm sure everybody would like to know that one.
Yes, we don't have a cure yet, but what we know is, we know many more, we have many more information as to what happens, actually what the lymphoma does with the environment in the skin. And this is a very important step to know, because those cancerous cells send signals out to other immune cells who live in the skin and other cells, and to get them to support their growth and their survival. And so by knowing this, and by finding out all these steps and how the cancer cells communicate with their environment, this is important to develop therapies that actually can block this interaction, and maybe is also more helpful in preventing it from coming back, and actually a step forwards a cure. And while we cannot still not promise a cure, but we have learned how those cancer cells communicate, which is very, very critical. And by doing this, I mean, stepwise, it's really, I think we're further ahead currently, but still there's so much to know. And I think I'm not sure if I'm hoping we will find something in the next 10, 20 years. This is how research goes. When I started 20 years ago, we didn't know what we know now. So it's a long, you know, approach. It's, but we know so much more than we knew 20 years ago. But unfortunately,
which is very encouraging.
Yes, very encouraging. There are a lot of investigators. And we had in Barcelona, we had the World Congress, and which was very, very good and exciting, you know, research data. This will be translated into treatments, but this takes time, because we also want to make sure that new treatments developed also do no harm to you as a patient.
Right, definitely.
Yeah.
Well, thank you so much. We are just so grateful for your time and expertise, and thank you for sharing with us today. We're just very appreciative. So thank you. And everybody, this does conclude our webinar for today. So thank you, Dr. Querfeld. We hope that you have a wonderful rest of your day, and everybody, you as well. So thanks for joining us.